be the moderator for this session. Welcome to the Season 2, Episode 5 of OMFS MCleanDen Alumni Webinar Series. All right, so I'll begin with introducing our speaker for this evening, Dr. Muhammad Ridwan bin Yeop Ismail. Dr. Ridwan is currently the head of Department of Oral and Maxillofacial Surgery, Hospital Tuanku Fauzia, Perlis. He graduated with DBS from University Kebangsaan Malaysia back in 2005. He was a dental officer in the Oral and Maxillofacial Surgery Department, Hospital Sultanah Bahia Alostar, before he pursued his specialist training in University Malaya from 2009 to 2013. Okay, before we begin, may I remind all participants to ensure that your microphone is off or muted. And if you have any question for Dr. Ridwan, please feel free to type in the chat box. Without further ado, let's welcome Dr. Ridwan with his presentation entitled Transconjunctival Approach with Lateral Cantotomy and Inferior Cantolysis to Infraorbital Rim and Orbital Floor. Dr. Ridwan, please.
Assalamualaikum and very good evening to all. Thank you, Dr. Daniel, for the short and brief introduction. Yeah, can everybody can hear me?
Yes, Dr. Ridwan.
Yes, okay. Before I start, I would like to say thank you very much to the organizing committee who gave the opportunity to me to share something that I think worth to share, even though I think it's a small thing, but in my opinion, it's something a little bit different, something that worth to share among colleagues. Yeah, in terms of to improve what we call that our technique in transconjunctival approach. Basically, it's a transconjunctival approach combined with combination of lateral cantotomy and inferior cantolysis also in order to access the infraorbital rim and orbital floor in the case of fractures, maxillofacial fractures such as orbital floor fractures, blowout fractures, Lefort 2 fractures, and also zygomatic complex fracture with inferior orbital rim involvement. Yeah. All right. So now we go to the first slide, which is the definition. Usually we start with definition. What is transconjunctival approach? Right. This is, as I think is everybody already knows about this. It is an incision made through lower lid conjunctiva, and it's actually first described in 1924, very long time ago, by Bogate for the removal of lower eyelid fat. Initially, it is done for the removal of lower eyelid fat, but after that, it is used what we call that in terms of access to repair the orbital floor rim fracture, and also what we call that lateral wall of the orbit fractures in maxillofacial trauma. All right. As we all already know, also I think the main advantage of a transconjunctival approach is aesthetic result, whereby the stitches and also the the scar is hidden inside the conjunctiva, right? If compared to a skin incision or transcutaneous approach. So apart from aesthetic results, aesthetic results, a few another advantages of this approach it's the ability to reach the periosteum, what we call that through transconjunctival incision to what we call that to allow access to aggregate portions of the orbit. For instance, access to the floor of the orbit, the infraorbital rim, the upper edge of anterior maxilla, and also the middle wall of the orbit behind the posterior lacrimal crest. Right. So in addition, what we call that combination with transconjunctival approach is the lateral skin incision, followed by lateral cantotomy and cantolysis, will allow the periosteum to be elevated superiorly for us to repair the fracture, let's say involving the frontozygomatic suture. All right. I think everybody already aware regarding this. This is another advantage of transconjunctival approach. It decreases the risk of postoperative eyelid retraction, which varies from scleral show to persistent ectropion. Yeah. And this approach also compared with the other approach, the incidence of ectropion is lower, for the treatment of orbital trauma based on previous studies. Okay, transconjunctival approach can be divided into preceptal and retroseptal. Okay, preceptal, as shown in the photo, in the sagittal view of the photo, is defined as an incision directly below the lower tarsal border and a suborbicularis oculi. Okay, if you can see from this photo, the preceptal is actually in between orbicularis oculi muscles and also the septum, the orbital septum. We call it as preceptal incision. The another one, which is which I have been doing for the time being, is retroseptal. Yeah, the incision is actually in the depth of fornix, and it's what we call that. It can be directed to the rim and orbital floor. It's actually a more simpler and direct for and a direct what we call that. It's direct technique, for us to access the infraorbital rim and also the floor of the orbit if compared to preceptal incision. Okay, there are a few advantages of preceptum, preceptal incision. The advantage, of course, it's scarless, excellent patient acceptance, because of scarless surgery, and then the disadvantage, it increased risk of tarsal plate injury because incision is very near to the tarsal plate, and then the risk, of course, the risk of ectropion. Whereby the retroseptal incision, there are a few advantages and disadvantages. So the advantages include the incision at anatomical landmark, which is in the fornix, the deeper part of the transconjunctiva, the conjunctiva, and then it direct to the rim, to the orbital rim and orbital floor. So that it will, how to say, the risk of entropion will be less. Okay, the disadvantages include a risk of injury to the eyeball because the incision is near the eyeball, can cause prolapse of the orbital fat, and then it can cause additional disturbance of the intraorbital connective tissue framework, and additional scar in the anterior part of the intraorbital fat system may influence the eye movement and also can participate in the development of enophthalmos. All right, from the photo, I think you to make you all to understand better. All right, the lateral cantotomy actually is the incision of the lateral canthal ligament of the eye at the lateral part of the eye. Okay, you do incision about 1 centimeter along the canthal, which is along the skin crease at the lateral part of the eye. We call it as lateral lateral cantotomy. Cantolysis actually is defined as incision at the lateral canthal tendon. Okay, anatomically, we have a lateral canthal ligament can be divided into two parts, which is superior and also the inferior. The one that we cut is actually the lower one because we want to increase the exposure and at the same time to reduce resistance during retracting the lower part of the eyelid. And of course, with this, we increase the surgical access to the rims, to the floor, okay, and then as well as to the lateral wall of the orbit. Okay, just want to recap lah. This apart from transconjunctival approach, okay, there are transcutaneous approach which are most of us are familiar with. Okay, it's named as a subciliary incision, or also known as a lower blepharoplasty, subtarsal, also known as lower or mid eyelid incision, and infraorbital incision, yeah, direct to the infraorbital rim, as shown in the photo. Okay, same with transconjunctival approach also. Transcutaneous approach also has advantages and disadvantages. I think most of us are familiar with this and already aware regarding the disadvantage, the advantage, and also disadvantage of the techniques. Yeah. All right, we go to the instrumentations. Without proper instrumentation, I think a bit difficult for us as a surgeon, yeah, to do the surgery. Yeah, in my clinic, in my hospital, we are a bit fortunate because we can get we have the what we say the important or the suitable instrument that we can use in the small or limited areas like infraorbital how to say like infraorbital region. And this is the armamentarium or instrumentation that we should have. All right, we should have of course this one is orbital flow retractor. Think this is not the exact infraorbital retractor. We modify the tongue depressor, you know, to become the orbital flow retractor. Maybe other places also do the same thing. Right, all of these are the small instruments, yeah, small instruments whereby this is the how to say this is the micro instruments, yeah, micro instruments, namely the tissue tissue scissor, okay, together with stitch scissor, yeah, and then the small tooth tissue forceps and then non-tooth tissue forceps, and also the stitch holder, yeah, stitch holder. So this apart from this, okay, this is the important instrument that we should have as well, what we call it as Desmares. Okay, Desmares actually come in a few sizes. It has small, small, medium, and large. The larger one. So I think the one that we have is a small and a medium one. Okay, and then of course our common instrument also, which is the small Langen bag, all right, or the cat's paw can be used, okay, to retract the infraorbital region. All right, sorry because it's very small. Quite small. Okay, these are the switches that we use, yeah, that we use. So intraoperatively we use 6O Vicryl 6O Vicryl to approximate the periosteum and also the conjunctiva. And then for the lateral part of the eye, which is the lateral ligament that lateral canthal ligament that we cut, we reapproximate back using non-resorbable sutures. Name is we always use 50 50 or 80 bond, yeah, 50 or 80 bond. Okay, I think in the intraoperative procedures, and I think same with the cutaneous techniques as well, start from LA given until the procedures, except from lateral cantotomy and cantolysis lah. Right. Okay, we go to the procedures, since because I want to share the how we do, yeah, how we do, and how I have been trained, yeah, to do the transconjunctival approach. All right. In this photo, actually, want to show the how the lower leg is retracted, yeah, retracted before we give LA. Usually the LA we give superficially, yeah, superficial, just at the superficial part of the conjunctiva. Right. So before that, when you see the location of orbital floor retractor, usually I will put the orbital floor retractor just posterior to the orbital rim, yeah, just posterior to the orbital rim generally, yeah. Let's say if multiple, let's say if the fracture is comminuted, severed fracture, that one is different story. All right. So after we give a local at the conjunctiva, as I showed before, okay, all right. So and then we give also local at the lateral canthal region, at the lateral part of the eye. And then before we cut the lateral part of the eye, usually I will clamp of the lateral canthal region before I do lateral canthotomy. Actually, it's tips so that we will control the bleeding at the area. But sometimes still bleeds, that we use cautery to reduce to stop the bleeding. Okay. Usually we start with cutting of the lateral part of the eye. We call it as lateral canthotomy. All right. So before we do lateral canthotomy, this superior part, sorry, the upper eyelid and lower eyelid, we need to retract properly, yeah, before we do incision over the lateral part of the eye. Usually I will use the line, the crease, the skin crease line at the angle of the eye. Right. So once you cut, this is how lateral canthotomy done. Yeah, we can cut using a scissor, and deepen, and then followed by electrocautery, yeah, to deepen. So we can cut until we can see until we can reach the periosteum, or until the bone, yeah, at this area. Usually I will cut about 1 centimeter lah, from the angle of the eye, yeah. Okay, after we do lateral canthotomy, right? Okay, this is how it's look like, how the procedure look like after a lateral canthotomy, yeah. So after lateral canthotomy, followed by, yes, this, right, followed by, okay, inferior cantolysis. Okay, most of patient I do this. I think most of procedures, all the procedures, I do inferior cantolysis, so that we can expose this area freely. Yeah. Right. All right. So once we do lateral canthotomy and also cantolysis, and then the next is incision of the conjunctiva. Right. We can I think usually I'll use a blade, yeah, a blade to incise the conjunctiva, and then followed by electrocautery. Yeah. Sorry, from lateral part. Usually I'll start from the lateral until the medial part. Yeah, until the medial part of the eye of the conjunctiva. Right. Okay. As I mentioned just now, most of the time I'll use retroseptal incision because I think it's if compared to preceptal incision, I think it's a bit simpler and direct to the rims and also to the floor compared to preceptum. Okay, this is how the incision is done from the lateral of the from the lateral part extend to the medial part, right? Okay. Okay, this is how it looks like after the incision and after elevated, after the periosteum is elevated anteriorly and also posteriorly. Yeah, right. Okay. As I mentioned just now, I think when we extend when we do the lateral canthal the skin incision followed by lateral canthotomy and also inferior cantholysis, actually we can expose the area, can expose the lateral of the orbit from my experience. Let's say if the fracture is involved, the under how to say, below the frontal zygomatic suture, most of the time this area can be exposed properly and can be palpate. But let's say if the fracture is on the frontal zygomatic fracture itself, sometimes we can expose and plate, sometimes we can expose but we cannot plate. It depends on the laxity of the skin as well. Yeah, because it's considered high up. And I think in that case, let's say if the fracture is involving this area, just next to the, let's say, just next to the inferior orbital rim, right? So this area can be exposed well and can be palpate, can be plated, without the needs of additional lateral eyebrow incision. Yeah. All right. Once we finish plating in the area, okay. Usually I'll close the conjunctiva first, or sorry. In terms of closure of the incision, yeah. Usually, most of the time, I think every time, all patients, okay. I will suture the periosteal layers and also followed by conjunctiva layers. It means that two layers, periosteum to periosteum and conjunctiva. All right. So for periosteum and the conjunctiva, I have been using resorbable sutures, Vicryl 6O. Yeah, and then for the closure of the corner of the eye, so you need to approximate. We need to approximate the upper and lower canthal region, as shown in this photo. You just need to approximate here and also here. Okay, this is the one that we cut, right? So once subtracted, it will be here. So most of the time, I think all the time, okay, we approximate the upper and lower canthal region, right? So that it will, so the contour of the eye will remain intact. Okay? No need to resuture the inferior limb of canthal ligament, the one that we cut, the inferior limb of the canthal ligament. That one no need to resuture back. Just resuture the lateral canthal, the main lateral canthal. that we cut before. Then and then all the time, I've been using Etibond XL50, which is non-resorbable suture. Okay. All right. Okay. Usually we'll suture the periosteum first, and followed by conjunctiva. Right. Conjunctiva can be sutured continuously or interrupted. It's up to us. I mean, it's how to say it? It can be done in such ways. Okay, and after that, right, this is how it looks like, okay, after the conjunctiva is closed. Okay, right. And once you close the periosteum and conjunctiva, okay, we close we reapproximate the lateral part of the eye. Okay, and then followed by resuture the incision that we made on the skin. Okay, as shown in this photo. All right. This is the photo of our patients that have been done few years back. So this actually is a photo that we took 1 hour, 1 week after surgery. That you can see this how to say the suturing actually is involved the lateral part of the eye only. Yeah. Right. Okay, this patient actually sustained a fracture of fault 2, okay, with orbital floor fracture, and then we do a transconjunctival approach bilaterally, yeah, bilaterally, and reconstruction also. Okay, this a photo of patient who sustained fracture right zygomatic complex with inferior orbital rim fracture. So we did transconjunctival approach. Yeah, this photo we took 1 month after surgery. Right. Post-op care. I think post-op care compared to skin incision, I think almost similar. So the one that I've been using, actually it's a guide, Maxidex. It's a steroid-based eye drops, yeah, and then give antibiotics, of course, intraoperatively and also postoperatively, adequate analgesics, and also steroids for maybe 1 or 2 days, yeah. Okay, these are the complications, the post-op complication that may happen when we do transconjunctival approach. I think the most common complication are swelling, yeah, pain, blurring of vision, yeah, and chemosis. But most of the time, this one is temporarily. Okay, and then the uncommon complication of this approach include damage and abrasion to the cornea, damage to the extraocular muscles, and also eyelid malposition, particularly entropion. Yeah. Just want to share our experience. Yeah. Performing transconjunctival approach in the case where it is needed. Yeah. So we have been doing this since 2015 until today. So far, from our records, we performed in 59 patients so far. Some patient needs bilateral incision. I think certain patient. I think some patient only need bilateral incision based on the injury that patient had, and then all patient we perform a transconjunctival incision combined with lateral cantotomy and cantolysis. From the from the observation and simple audit that we do, none of our patients develop eyelid malposition, particularly entropion, because from the I think most of literature saying that the most common complication related to transconjunctival approach is entropion. Okay. All right. So we come to conclusion. This approach is I think is effective, is an effective surgical access to infraorbital rim, to orbital floor, and then to the middle orbital wall, and then the lateral wall of the orbit and frontozygomatic suture exact area. If compared to transcutaneous approach, incision, I think surgically may be similar in providing exposure and access, but aesthetically, I think it's superior to the other approaches with minimal complication. However, it should be performed meticulously, to avoid all those complications with some knowledge of anatomy of the orbital tissues. Okay, these are my references, right? Thank you.
Okay, thank you, Dr. Ridwan.
Yeah.
Okay. Any questions from the participants? Okay, Dr. Ridwan, actually, I wanted to ask, you mentioned just now you routinely perform lateral canthotomy for all cases.
Yeah.
Okay. All right. Even if, let's say, the fracture is not so extensive, not extended to the lateral aspect of the orbit, you will also do the lateral canthotomy?
Yes, because I think its access is very important, right?
Any other questions from the participants? No question for the participants? Any questions? Okay, there's one question here from Dr. Imran. So he's asking, may I know what kind of suturing do you do to suture the conjunctival?
Pardon? What kind of suture?
What kind of suturing do you do? I think he referred to suturing technique.
The suturing technique. Depends. Sometimes, sometimes I use simple interrupted sutures, right? Sometimes I use continuous sutures. Depends. There's no specific way lah.
All right. Okay.
But all this while I'm using the 660 vicryl. 660 vicryl because I was trained to use that. So if maybe other people or other surgeon they might using the other types of sutures, maybe different size, you know, because I think the 60 quite already quite small, quite thin, yeah. If you know, if compared to others.
Okay. Another question from Dr. Katiraban. The lateral canthus ligament is sutured to the orbital rim or to the upper canthal ligament?
The lower one, is it?
Yes, I think you refer to the lower one. Yeah.
Okay. Basically, we just reapproximate back the area that we cut.
So
right?
it's back to the ligament itself.
Yes, true. No need to resuture. Well, how to say? To suture to periosteum. Not necessary. Right? As long as it can be approximated at the lateral part, should be fine.
Okay. Right. Next questions from S. I'm not sure who is this. Okay. Thank you, Dr. Ridwan. Can I ask what material do you routinely use to reconstruct the orbital floor following this approach?
The material that we use to reconstruct
Yes, orbital floor.
orbital floor.
Mm.
So depends. Depends on the availability of material that we have. You know, sometimes I use osteomesh. You know, sometimes you use mesh plate, right? Right. Osteopore. Sometimes I use osteopore. Sometimes I use mesh plate. Yeah.
Is there any particular
For
reason
pits,
why?
for pits case, contohnya for pits case, of
Yeah.
course, right? For pits case, I mean, if compared to adult, of course, it is a bit different, right? For pits case, a younger patient, of course, you want something resorbable, right?
Mhm.
So we use osteopore, yeah, which is available, and then for adult patient, most of the time I use osteomesh.
Okay. All right. Next question from Dr. Rubindran. Any advices or tips if you have ever experienced entropion post-operative?
Yeah, for the yeah, thank God. Thank God. So far, I never encountered any what call it delayed complications in my case lah. If you ask me whether I can treat entropion, I don't have experience treating entropion. But so far, I don't have problems regarding the entropion because all patients we reviewed until a few months. I think same. I mean, with other centers as well, right? So maybe 2 months or 3 months, most of the time patient are okay already. And then since patient don't have any problems, delayed complications, yeah, usually we discharge the patient after that, right? Mm.
Okay. Next question from Dr. Ong Wan Chun.
Yeah.
It's asking whether Dr. Ridwan still perform transcutaneous approach for a patient. If yes, case that doctor will choose for transcutaneous approach.
Yeah, since I think I quite confident now to do, I mean, in doing transconjunctival approach. So since 2015 until now, I've been doing transconjunctival approach. I think before that, yes, subciliary, most of the time is subciliary. So since I think it's to say, um, I think I'm more confident. I mean, in terms of aesthetic and everything. So that's why I choose to do a transconjunctival approach compared to other. Unless if a certain patient, right, a trauma patient, let's say we have to do, let's say trauma patient with existing wound involving the infraorbital fractures, infraorbital ataupun uh, on the skin, right? And then I think that one is a different story because we will use the existing incision, the existing wound, because most of cases like that, I mean in Perlis or the other places, I'm not so sure. In Perlis, I think most of cases, if like that, is involved also the orbit, you know. So while the ophthalm team do the soft tissue part of the orbital, we go in together with them to plate the area. Some of cases, no, but most of cases, if there is no extraoral wound, no infraorbital wound, we do transconjunctival approach as usual.
Okay. Next question for you, Dr. Ridwan.
Hmm.
What's your opinion if we left the area, the incision, without suturing?
The one I do not know how to comment. Yeah, because yeah, I think maybe a few people have been doing that and is doing that. I'm not so sure. But I never done it without suturing. Yeah, without suturing. But to me, I believe in once we open, we do incision, we should do we should what that suture back that area. especially when we reconstruct the floor of the orbit, right? So we put something there so that in order for the reconstruction plate or also mesh to stay in place, we need to suture the orbital the periosteum, and followed by the transconjunctival. I never leave transconjunctival without suturing. Yes.
Okay. The next question from Dr. Karthik. How many sutures will you place in the conjunctival? Is there any specific numbers?
No. I think lesser the better. As long as you can approximate the conjunctival should be fine. Yeah. Because let's say if you don't, if you suture too much, maybe it can cause, a source of infection also, right? So to me, that I said just now, sometimes I do suture. What could I just put 3 or 4 sutures sometimes, and then sometimes I put how to say, but most of the time, I do what we call that simple interrupted suture. As long as that area sutures maybe 3 or 4 sutures should be fine.
Okay. The next question is from Dr. Jas. Any
Yeah.
routine post-op intraocular pressure monitoring?
So far, no. But of course, we monitor also, right? We monitor for, I think, same like other procedures as well, kan? Like a transcutaneous approach also. We still monitor patient for bleeding, for the true bulbar hemorrhage, same. But post-operatively, no need. My way, and then I learned that way. No need for what call that iPad, something like that. Just treat as what how we do skin incision. No specific apa nama difference. No different. I think there's no different from the normal way, the way that we do.
Okay. Right. So any other questions from the participants? Okay. May I remind participants, we will be sending a link in the chat box. Is feedback form. Please fill out the feedback form in order for you to get your certificate. All right. Thank you. Thank
Okay,
you.
no more question?
I think no more, Dr. Ridwan. Thank you so much, Dr. Ridwan, for sharing your experience.
Yes.
Really.
Welcome.
All right. Okay. I think that's all for this evening. Thank you again, and thank you everyone for joining us this evening. Thank you very much, and have a good night.
Okay. Good night.